At 6:42 a.m., the emergency department doors burst open as paramedics rushed in a patient on a stretcher. The cardiac monitor screamed in irregular bursts. Blood pressure was barely measurable. Oxygen saturation was falling, despite high-flow oxygen. The man on the stretcher was conscious, but only just. His skin pale, clammy, his breathing shallow and rapid. Every movement seemed to cost him enormous effort. There was no visible trauma, no external bleeding, no signs of an accident. Yet something inside his body was failing at alarming speed. A paramedic shouted a brief report. Sudden collapse at home, severe pain, rapid deterioration during transport. Intravenous lines were already in place. Fluids were running wide open. The patient's pulse was thready, barely palpable. Within seconds, the emergency team took over, transferring him to a resuscitation bay as alarms echoed through the room. For the physicians, this was the most dangerous kind of emergency, the kind where the cause is hidden. Initial vital signs painted a grim picture. Heart rate over 130 beats per minute. Systolic blood pressure hovering around 80 mmHg. Respiratory rate climbing past 30. The patient tried to speak but could only manage fragmented words before gasping for air. His eyes showed fear, not panic, but the instinctive fear of someone who senses that something is profoundly wrong. There was no time for long questions. Blood was drawn for urgent labs. A bedside ultrasound probe was placed on the chest and abdomen within minutes. The emergency physician scanned rapidly, searching for obvious answers. Fluid around the heart, internal bleeding, collapsed lung. Nothing obvious appeared. The screen offered no immediate explanation. That uncertainty was dangerous. The patient's condition continued to deteriorate. His mental status began to fade. Skin mottling crept up his legs. The monitor displayed intermittent arrhythmias, signs that the body was struggling to maintain circulation. A nurse called out a rising lactate level from the first blood gas, indicating severe tissue hypoxia. Whatever was happening inside him was already starving his organs of oxygen. In situations like this, every minute matters, but guessing wrong can be fatal. The emergency team faced a narrowing window. Without a clear diagnosis, treatment was little more than damage control. Fluids, oxygen, vasopressors. But these measures only buy time. They do not stop the underlying process. Someone asked the question every emergency physician dreads: what are we missing? There were no obvious clues, no history of heart disease on record, no signs of infection on initial exam, no trauma, no known chronic conditions. Just a previously healthy adult male, now spiraling into shock. As preparations began for advanced imaging, the patient suddenly cried out in pain. Sharp, intense, unlike anything he had felt before. His blood pressure dropped again. The monitor alarmed louder. The room shifted from controlled urgency to near chaos, each clinician moving faster, voices sharper, decisions compressed into seconds. This was no longer a mystery that could wait. Somewhere inside the patient's body, a catastrophic process was unfolding, one that had likely been developing silently for days, perhaps weeks, without drawing attention. Now it had reached a tipping point. What the team did not yet know was that this moment, the collapse, the alarms, the desperate race for answers, was the final stage of a condition that is often missed until it becomes lethal. To understand how this patient arrived at the edge of death, it is necessary to rewind the story. Days earlier, his life looked entirely ordinary. Just 1 week earlier, there was nothing about this man that suggested he was heading toward a medical emergency. He was 38 years old, living in a suburban apartment on the outskirts of a large city. He worked as a project manager for a logistics company, a job that demanded long hours, frequent deadlines, and constant problem-solving, but little physical strain. Most days were spent seated in front of multiple screens, coordinating shipments and managing teams across time zones. Stress was a constant companion, but to him, it felt normal. His lifestyle was typical for someone his age. He did not smoke and drank alcohol only occasionally, usually on weekends. He exercised irregularly, short gym sessions when time allowed, long gaps when work became overwhelming. His diet was unremarkable, a mix of home-cooked meals and convenience food grabbed between meetings. He slept poorly, often fewer than 6 hours a night, but dismissed it as the cost of professional success. From a medical standpoint, he considered himself healthy. He had no known chronic illnesses, no diagnosed hypertension, no diabetes, no history of heart disease. His last routine medical checkup, nearly 2 years earlier, had been largely normal. Basic blood work had shown mildly elevated cholesterol, but nothing that triggered treatment beyond general advice to eat better and exercise more. He never followed up. Family history offered only subtle hints. His father had suffered a myocardial infarction in his early 60s. A paternal uncle had died suddenly from an unspecified cardiovascular event. These facts were known but never felt urgent, distant risks for a future version of himself, not problems of the present. In daily life, he was active and independent. He drove himself to work, helped his partner around the house, and spent weekends running errands or meeting friends. There were no limitations, no warning signs that stood out as alarming. To coworkers and family alike, he appeared slightly overworked, but otherwise well. The first changes were so minor that they blended easily into the background of everyday fatigue. Occasionally, he noticed a vague discomfort in his upper abdomen and lower chest, a pressure rather than pain. It tended to appear late in the evening or during particularly stressful days. Sometimes it was accompanied by mild nausea or a sense of bloating. He assumed it was indigestion, perhaps related to irregular meals or too much coffee. There were also fleeting episodes of back discomfort, deep and dull, radiating between the shoulder blades. They were brief and inconsistent. He attributed them to poor posture at his desk and long hours without movement. Stretching seemed to help. Painkillers were rarely needed. Importantly, none of these symptoms stopped him from functioning. He continued to work, to drive, to sleep, albeit restlessly. He did not feel sick. He did not feel weak. He did not feel like someone who needed medical attention. The human body has an extraordinary ability to compensate, and at this stage, his was doing exactly that. What he did not know was that beneath this outward normality, a dangerous process had already begun, one that does not announce itself loudly in the early stages, one that mimics benign conditions and exploits the tendency to rationalize discomfort. In retrospect, the warning signs were there, but they were subtle, intermittent, and easy to dismiss. And so, like many patients before him, he carried on with his routine, unaware that his condition was evolving silently, steadily, and toward a point where compensation would no longer be enough. The moment he crossed that threshold, everything would change. The symptoms did not arrive all at once. They appeared gradually, woven into the fabric of daily life, easy to explain away and even easier to ignore. It began with fatigue that felt disproportionate to his workload. By mid-afternoon, he found himself unusually drained, struggling to concentrate during meetings that normally required little effort. Coffee no longer had its usual effect. He blamed poor sleep, stress, and long hours. Reasonable explanations that required no further thought. Within days, the intermittent discomfort he had noticed earlier became more distinct. A dull, pressing sensation emerged behind the lower sternum, occasionally spreading upward toward the chest or backward into the upper spine. It was not sharp. It did not worsen with exertion. It did not resemble the dramatic chest pain portrayed in medical warnings. Most of the time, it faded on its own. There were moments, however, when the discomfort was accompanied by an unsettling sense of internal pressure, something deep and unfamiliar, as if the pain were coming from beneath the surface rather than from muscles or joints. These episodes lasted minutes, sometimes longer, and resolved without intervention. He never described the sensation as severe. At night, he began waking unexpectedly, not gasping for air, not in obvious distress, but restless, with a vague feeling of unease. On several occasions, he noticed his heart beating faster than usual, strong and deliberate in his chest. Checking the time, he would lie still, waiting for the sensation to pass. Eventually, it always did. He considered seeing a doctor more than once. But each time, the symptoms improved before the thought could turn into action. The human mind has a powerful tendency to interpret improvement as reassurance. There were also gastrointestinal changes, mild nausea in the mornings, a decreased appetite, occasional episodes of early satiety, where he felt uncomfortably full after small meals. These symptoms pointed in his mind toward digestive issues. He adjusted his diet slightly, cut back on spicy food, and took over-the-counter antacids. The relief was partial, but enough to reinforce his assumption. At no point did he experience syncope, shortness of breath on exertion, or crushing chest pain. There was no single symptom dramatic enough to override his internal calculus. Inconvenient, but not dangerous. What made the situation particularly deceptive was the inconsistency. Good days alternated with bad ones. Some mornings he felt entirely normal. On others, the discomfort returned without warning. This variability suggested a benign process, something functional rather than structural. Meanwhile, inside his body, the pathology was progressing. At a vascular level, forces were acting on a structure never designed to withstand them for long. Subtle changes in blood flow were altering pressure dynamics, slowly weakening tissue integrity. Each heartbeat added microscopic stress, imperceptible on its own, but cumulative over time. Laboratory markers, had they been checked, might already have shown early abnormalities, slight elevations, borderline values, nothing definitive. Imaging at this stage might have revealed a developing problem, but only if someone knew exactly where and how to look. No such evaluation was performed. By the end of the week, the symptoms had become more frequent. The discomfort lingered longer. The episodes of palpitations were harder to ignore. Still, life went on. Meetings were attended. Deadlines were met. Plans for the weekend were made. The body was compensating, but the margin was shrinking. The next phase would arrive suddenly without warning, transforming a collection of tolerable symptoms into a medical emergency that could no longer be dismissed. As the days passed, the symptoms stopped feeling new and began to feel familiar. Familiarity in medicine is often dangerous. The persistent discomfort in his chest and upper abdomen no longer triggered concern. It became part of the background noise of his day, flaring during stressful moments and receding when he rested. He learned which positions seemed to ease it, how to breathe through the pressure until it subsided. Adaptation replaced alarm. He postponed scheduling a medical appointment multiple times. Each delay was justified. Work was demanding. The symptoms were not constant. He told himself that serious conditions do not behave this way, that they worsen steadily, not in waves. The logic felt sound. At the same time, subtle changes were occurring that he did not consciously register. Walking upstairs left him slightly more breathless than before. His tolerance for physical exertion declined, but so gradually that it blended seamlessly into fatigue. When his heart raced unexpectedly, he attributed it to anxiety. Painkillers and antacids became routine tools. They dulled the discomfort without addressing its cause. This temporary relief reinforced the illusion of control, masking the progression beneath. Inside the body, compensation mechanisms were working overtime. Blood vessels adjusted their tone. Heart rate increased to maintain adequate circulation. Collateral pathways attempted to redistribute flow. These responses were effective, but costly. They placed additional strain on already vulnerable structures, accelerating the underlying damage. At an anatomical level, the affected vessel was changing. What had once been a stable, resilient wall was now under abnormal stress. Microscopic tears had begun to form within its layers, disrupting the normal architecture. With each cardiac cycle, pressure forced blood into spaces where it did not belong, further weakening the structure from within. This process was silent, There was no external sign, no fever, no visible swelling, no laboratory values screaming for attention. The body was still holding itself together. One evening after a long day, the discomfort intensified more than usual. The pressure became heavier, deeper, spreading across his chest and into his back. He sat down, waited, focused on breathing. After nearly half an hour, it eased. Exhausted, he went to bed. That night, he slept poorly. He woke several times with a pounding heartbeat and a sense of internal tension he could not explain. By morning, he felt drained but functional. He showered, dressed, and left for work as usual. This pattern, worsening followed by partial relief, was not a sign of improvement. It was a warning that the system was approaching its limits. In many vascular conditions, there is a narrow window between instability and collapse. During this phase, intervention can be life-saving, but it requires recognition. It requires suspicion. It requires action. None of those occurred. The final deterioration was already being set in motion. Structural integrity had been compromised beyond what compensatory mechanisms could sustain. All that remained was a trigger, sometimes as trivial as standing up, coughing, or a sudden increase in blood pressure. When that moment arrived, the body would have no margin left. The next event would not be subtle. It would not be gradual. It would be violent, overwhelming, and impossible to ignore, marking the abrupt transition from warning signs to full-scale medical catastrophe. The collapse came without warning. On a seemingly ordinary Thursday morning, the patient experienced a sudden, severe pain radiating across his chest and into his back, unlike anything he had felt before. The pressure, previously dull and intermittent, became sharp, constricting, and relentless. He gasped, clutching at his torso, and stumbled toward the kitchen. His partner, witnessing the abrupt change, immediately called emergency services. Within minutes, paramedics arrived. They found him pale, drenched in sweat, barely able to maintain consciousness. His speech was fragmented. He could only whisper short phrases, each interrupted by shallow, labored breaths. The initial assessment revealed tachycardia, with a heart rate exceeding 140 beats per minute, hypotension with systolic pressure below 85 mmHg, and oxygen saturation dropping to 88% despite supplemental oxygen. Peripheral pulses were weak, intermittent, and difficult to detect. Skin was mottled, a grim sign of poor perfusion. As paramedics worked quickly, they initiated intravenous access with 2 large-bore cannulas and began rapid infusion of isotonic fluids. They administered high-flow oxygen via non-rebreather mask and prepared emergency medications for circulatory support. Cardiac monitoring revealed intermittent arrhythmias and frequent premature ventricular contractions, signaling acute cardiovascular instability. The patient's mental status fluctuated. Moments of clarity were punctuated by periods of disorientation and confusion. He tried to rise, but his body failed him. Paramedics secured him on a stretcher and carefully immobilized him. Each movement was measured, precise, and urgent. One wrong motion could exacerbate internal injury. During transport to the nearest tertiary hospital, the patient's condition continued to deteriorate. Blood pressure dropped further, requiring initiation of intravenous vasopressors en route. Paramedics closely monitored his cardiac rhythm, ready to perform advanced resuscitative measures if needed. Every bump on the road, every turn, threatened to worsen his unstable state. Upon arrival at the emergency department, a multidisciplinary team was already waiting. Emergency physicians, critical care nurses, and anesthesiologists quickly transferred him to a resuscitation bay. The room was alive with controlled urgency, alarms from monitors, calls for medications, and rapid assessment of vital signs. Oxygen was escalated to mechanical support, as non-invasive measures proved insufficient. Initial bedside evaluation focused on rapid identification of life-threatening causes. Point-of-care ultrasound was performed immediately, scanning the chest, heart, and abdomen for evidence of internal bleeding, pericardial effusion, or pneumothorax. The abdominal cavity appeared free of gross fluid collections. The heart demonstrated mildly reduced contractility, but no tamponade. Pulmonary windows revealed no significant collapse, though the lungs appeared slightly congested. The findings were inconclusive, a classic scenario of an internal catastrophe not yet visible on initial imaging. Blood samples were sent for urgent analysis. Lactate levels were elevated, indicating systemic hypoperfusion. Hemoglobin was slightly decreased, suggesting ongoing blood loss or early hemodilution. Electrolytes were mostly normal, but subtle shifts hinted at impending metabolic derangements. The critical question hung in the air. What could destabilize a previously healthy adult so suddenly, without prior warning, and leave standard bedside evaluations largely unremarkable? Time was the enemy. Every minute wasted increased the risk of irreversible organ damage or death. As the team prepared for advanced imaging, the patient's pain intensified. He moaned, clutching his chest, sweating profusely. Blood pressure plummeted further, forcing escalation of vasopressor therapy. His skin became cold and cyanotic, lips turning a deep blue. He began showing early signs of confusion, unable to recognize even familiar faces. The emergency physicians recognized this as a window of extreme urgency. Stabilization measures were temporary. Without immediate identification and intervention, the underlying process would overwhelm the patient completely. The race against time had officially begun. Within moments, arrangements were made for rapid transport to the CT scanner. Continuous monitoring, intravenous support, and pre-oxygenation accompanied him. Every heartbeat mattered. Every second counted. The next diagnostic step would either reveal the hidden threat or leave the team guessing, a distinction between life and death. The patient was rushed directly from the resuscitation bay to the computed tomography CT suite, accompanied by a team of emergency physicians, critical care nurses, and anesthesiologists. Every step was calculated, every movement monitored. Portable monitors tracked his vital signs continuously: heart rate, blood pressure, oxygen saturation, and ECG. Intravenous vasopressors maintained perfusion, while high-flow oxygen attempted to sustain oxygenation. In the CT suite, the medical team faced a crucial challenge. The patient was unstable, yet rapid imaging was essential. A contrast-enhanced CT scan of the chest, abdomen, and pelvis was initiated to search for internal bleeding, vascular disruption, or other life-threatening pathology. The scan had to be performed efficiently, minimizing patient movement, while ensuring diagnostic clarity. Initial slices of the chest revealed subtle but critical abnormalities. The aorta, normally smooth and uniform, showed evidence of an intimal tear in the descending thoracic segment. Blood had begun to dissect between the layers of the vessel wall, forming a false lumen. This was a classic case of an acute aortic dissection, an extremely high-risk vascular catastrophe. The contrast dye highlighted the separation clearly, showing blood flow within both the true and false lumens. Meanwhile, slices of the abdominal cavity revealed no free fluid or obvious hemorrhage, which initially misled some members of the team. The absence of overt bleeding did not diminish the danger. The dissection extended along a critical portion of the aorta, threatening major branch vessels that supply the kidneys, spinal cord, and gastrointestinal tract. The patient's blood work arrived simultaneously. Hemoglobin was modestly decreased, consistent with early internal blood loss. Lactate levels were elevated at 5.2 mmol/L, confirming tissue hypoperfusion. Electrolytes were largely normal, but rising creatinine suggested the kidneys were already under stress. Coagulation studies were within acceptable limits, which would later facilitate surgical planning. A bedside echocardiogram had been performed concurrently in the emergency department. It revealed mild left ventricular dysfunction, likely due to acute afterload increase from the dissection, but no pericardial effusion. The aortic valve was intact, ruling out retrograde involvement at that level. These details refined the surgical strategy. The dissection was descending, not involving the ascending aorta, making emergent endovascular repair feasible. The radiologist highlighted the critical findings, over the secure hospital network. Three-dimensional reconstructions of the aorta were generated, demonstrating the extent of the dissection and the diameter of the true and false lumens. These images were crucial for planning access points, stent sizing, and anticipating potential complications. At this stage, time was a decisive factor. The dissection was actively propagating, and every heartbeat threatened to worsen the tear. The patient's vital signs were unstable but manageable with pharmacologic support. Delay beyond the next hour could result in rupture, organ failure, or death. As the imaging concluded, the team gathered for rapid interpretation. The findings were unequivocal: a type B acute aortic dissection, with evidence of compromise to distal branch vessels. It was rare, lethal if untreated, and required immediate intervention. The window for action had arrived. Advanced diagnostics had revealed the invisible enemy. The hidden catastrophe inside the patient's chest was now visible, quantified, and ready to be confronted, but only by a precise, coordinated, and high-risk surgical procedure. This moment marked the transition from suspicion and stabilization to definitive treatment planning. The next step would require consultation with vascular surgeons, anesthesiologists, and interventional radiologists, a true medical concilium that would decide the fate of the patient's life. With the CT scans complete and the extent of the aortic dissection now clear, a rapid but comprehensive medical concilium was convened. In a specially designated trauma conference room adjacent to the intensive care unit, senior vascular surgeons, interventional radiologists, anesthesiologists, and critical care specialists gathered. The patient remained in the resuscitation bay, supported by vasopressors and high-flow oxygen, his condition precarious, yet stable enough to allow deliberation. The lead vascular surgeon began the review. Using the 3D reconstructions from the CT, he illustrated the anatomy on a large monitor. The tear originated in the descending thoracic aorta, extending into the abdominal aorta, with partial compromise of several branch vessels, including the renal and mesenteric arteries. The true lumen was narrow, the false lumen pressurized, and the vessel wall dangerously weakened. The risk of rupture or malperfusion was imminent. Discussion quickly turned to treatment strategies. Two primary options were considered: open surgical repair or endovascular stent graft placement, TEVAR, thoracic endovascular aortic repair. Each had advantages and risks. Open surgical repair would involve a thoracotomy, direct clamping of the aorta, excision of the dissected segment, and placement of a synthetic graft. It offered direct control over the vessel, but carried significant morbidity: prolonged anesthesia, massive blood loss, high risk of spinal cord ischemia, and an extended recovery period. For a patient already hemodynamically unstable, this approach carried a mortality risk of 20–30% even in high-volume centers. Endovascular repair, TEVAR, involved the insertion of a stent graft via the femoral artery, navigating through the iliac vessels and aorta under fluoroscopic guidance to cover the intimal tear. This minimally invasive approach avoided thoracotomy, reduced operative stress, and allowed rapid exclusion of the false lumen. Risks included stent malposition, endoleak, vessel rupture during deployment, or occlusion of critical branch vessels. Precise sizing and placement were imperative. The anesthesiologist highlighted the patient's fragility. Blood pressure swings were already severe, and he had limited cardiac reserve due to acute afterload stress from the dissection. Open surgery would likely destabilize him further. TEVAR offered the possibility of stabilization under controlled conditions. A critical consideration was timing. Every additional minute increased the risk of rupture. Waiting for the operating room to prepare for open repair would take at least 90 minutes. TEVAR, by contrast, could begin within 30–40 minutes. The team collectively recognized that speed, precision, and minimal physiological insult were paramount. After intense discussion, the decision was made. The patient would undergo emergent TEVAR. The plan was meticulously detailed: access, percutaneous entry through the right femoral artery, with contralateral femoral access for wire guidance. Imaging. Real-time fluoroscopy, combined with intravascular ultrasound to guide stent placement. Stent selection. A custom-sized thoracic stent graft covering the primary tear while preserving perfusion to critical branch vessels. Backup. Surgical team on standby for immediate conversion to open repair if stent deployment failed or rupture occurred. Anesthesia and monitoring. Continuous invasive arterial pressure monitoring, transesophageal echocardiography, and rapid transfusion readiness. The vascular surgeons emphasized that while TEVAR was technically feasible, precision was non-negotiable. A millimeter's error could compromise renal perfusion or worsen the dissection. Every team member had a defined role, and contingencies for complications were rehearsed verbally before the patient was moved. Finally, the chief of critical care summarized, "We have one chance. Everything we do now determines whether he lives or dies. There is no room for hesitation." With the plan agreed upon, the patient was prepped for transport to the hybrid operating suite, where fluoroscopy and surgical support were available simultaneously. Lines were secured, vasopressors adjusted, and the patient sedated, but not paralyzed, to allow spontaneous respiration until full anesthetic induction. The consilium dispersed, leaving a tense but coordinated team ready to execute the procedure. In these moments, the line between life and death was razor thin. The patient's survival depended entirely on precision, speed, and the flawless execution of a plan born from collective expertise. The stage was set. The next phase, the operation itself, would transform static images and theoretical plans into high-stakes action within the human body. A perfect scenario for step-by-step visualization in medical animation. The hybrid operating suite was prepared for immediate intervention. Fluoroscopy machines, vascular imaging monitors, and surgical instruments were ready. The patient lay supine on the table, sedated and intubated, with continuous arterial line monitoring. Vasopressors maintained perfusion, and transesophageal echocardiography provided live cardiac and aortic imaging. Every member of the team was positioned and accounted for. The lead vascular surgeon at the table, interventional radiologists controlling imaging, anesthesiologists monitoring vitals, and nurses managing instruments and medications. Step 1. Vascular access. Percutaneous access was achieved through the right femoral artery using a micropuncture technique. A guide wire was carefully advanced through the iliac artery into the descending thoracic aorta under fluoroscopic guidance. The contralateral femoral artery was also accessed for a secondary guide wire to provide stability and allow for accurate stent positioning. Sheaths were inserted to accommodate the stent delivery system, with constant saline flush to prevent thrombosis. Step 2. Aortic mapping and measurement. Using the live fluoroscopy feed combined with preoperative 3D CT reconstructions, the surgical team precisely mapped the entry tear and determined the optimal landing zones for the stent. The proximal landing zone was carefully chosen to avoid covering critical branch vessels, while the distal zone had to ensure complete exclusion of the false lumen. Intravascular ultrasound confirmed lumen diameter, wall integrity, and branch vessel positions. Step 3. Guide wire navigation. A stiff supportive guide wire was advanced across the dissected segment. This wire had to remain entirely within the true lumen of the aorta. Navigating through a dissected vessel is inherently dangerous. A misplacement into the false lumen could result in rupture or malperfusion of downstream organs. The surgeons manipulated the wire with millimeter precision under continuous imaging. Step 4. Stent graft deployment. A custom-sized thoracic stent graft was mounted on the delivery system. The graft was advanced over the guide wire to the designated position. The team paused to confirm placement with multiple imaging angles, ensuring coverage of the intimal tear without occluding branch vessels. Once aligned, the stent graft was slowly deployed. The self-expanding stent immediately conformed to the true lumen, sealing the entry tear. Contrast injections confirmed that blood was no longer entering the false lumen. Step 5. Verification and adjustments. After initial deployment, the team performed angiography to evaluate flow dynamics. Some minimal endoleak, a small passage of blood around the stent, was identified at the distal edge. Using balloon catheters, the surgeons carefully molded the stent to the vessel wall, eliminating the leak. Blood flow to the renal and mesenteric arteries remained intact, confirmed by selective contrast injection. Step 6. Monitoring for complications. Throughout the procedure, the anesthesiology team monitored hemodynamics closely. Brief drops in blood pressure occurred during stent manipulation but were countered with intravenous vasopressors. ECG monitoring showed transient arrhythmias, likely caused by aortic stretch, which resolved spontaneously. The surgical team remained poised, ready for immediate conversion to open repair if rupture occurred. Step 7. Final imaging and closure. Once the stent was fully deployed and no endoleak remained, a final fluoroscopic run and intravascular ultrasound confirmed correct positioning and patency of branch vessels. Sheaths were removed, and vascular access sites were closed percutaneously using suture-mediated closure devices. Hemostasis was confirmed, and the patient's circulation was stable, with normalized blood pressure and improved perfusion. Step 8. Immediate postoperative care. The patient was transferred to the intensive care unit under close hemodynamic monitoring. Vasopressors were gradually weaned as blood pressure stabilized. Postoperative imaging within the first hour confirmed proper stent position, full exclusion of the false lumen, and adequate perfusion to the renal, mesenteric, and lower limb arteries. This operation exemplified the precision and coordination of modern endovascular therapy. Minimally invasive yet life-saving, guided by imaging and real-time feedback. For a 3D medical animation, the sequence provides a perfect visual narrative. Vascular access, guidewire navigation, stent deployment, and hemodynamic restoration, capturing the dynamic interplay of anatomy, instruments, and the patient's physiology. Despite the apparent success, the procedure was not entirely without risk. Aortic repair of this nature carries the possibility of sudden complications, which could reverse all progress in an instant. The next critical phase would test the team's ability to manage unexpected events, the moment when a complication arises, and every second matters. The stent graft had been deployed successfully, and initial imaging suggested that blood flow through the true lumen was restored. Perfusion to the renal and mesenteric arteries was confirmed, and blood pressure stabilized. For a fleeting moment, the surgical team allowed themselves a sigh of cautious relief. Then, a sudden change occurred. On the monitors, systolic blood pressure began to drop rapidly, from 120 milliliters to below 70 milliliters within minutes. Heart rate accelerated to 150 beats per minute. Oxygen saturation fell from 98% to 90%. The patient's skin, previously pink and perfused, now became mottled and cold. Alarm lights flashed, and the operating room erupted into urgent activity. The anesthesiologist immediately administered additional vasopressors, while the surgeons reassessed the angiographic images in real time. The source of instability became apparent. A distal extension of the dissection, previously unrecognized, had allowed blood to flow into a secondary false lumen, creating a sudden endoleak. The pressure in this false lumen was high enough to divert blood away from critical organs, effectively recreating the preoperative state. The team had to act fast. Step 1. Rapid identification. Using live fluoroscopy, the surgeons traced the new endoleak. Contrast highlighted the secondary channel, flowing from the distal end of the stent graft into the unsealed portion of the aorta. Immediate recognition was vital. Every second of hypoperfusion increased the risk of irreversible organ damage. Step 2. Extension of the stent. A second, overlapping stent graft was rapidly selected and prepared for deployment. The guide wire was navigated distally through the true lumen, past the secondary dissection. The delivery system was advanced with extreme caution, as the vessel wall remained fragile. Any misplacement could rupture the aorta, a catastrophic scenario with near certain mortality. Step 3. Deployment and sealing. The second stent graft was deployed, carefully covering the newly identified entry point. Balloon molding was performed to ensure full apposition of the stent to the aortic wall. Contrast injections confirmed that the endoleak was sealed and that blood flow was redirected exclusively into the true lumen. Perfusion to the kidneys and intestines was immediately restored. Step 4. Hemodynamic stabilization. As the leak was controlled, blood pressure began to rise, heart rate gradually decreased, and oxygen saturation improved. The anesthesiologist tapered vasopressors slowly, while monitoring for signs of reperfusion injury, which could occur when previously underperfused organs suddenly receive blood flow. Continuous arterial blood gas analysis guided fluid and electrolyte management. Step 5. Confirmation and postoperative imaging. A final angiographic run confirmed complete exclusion of both the primary and secondary false lumens. Branch vessels were patent, and no residual leaks were evident. Intravascular ultrasound validated that the stent grafts were fully expanded and well seated against the vessel wall. Step 6. Reflection and vigilance. Although the immediate crisis had passed, the team remained hyper-vigilant. Complications from aortic repair can recur suddenly, including stent migration, rupture, organ ischemia, and arrhythmias. The next 24 hours would be critical for monitoring in the intensive care unit. This episode demonstrated the razor-thin margin between success and catastrophe in vascular surgery. One unrecognized extension of the dissection had nearly reversed the entire procedure, threatening the patient's life in an instant. Yet, the team's preparation, rapid recognition, and decisive action turned a potential disaster into a survival scenario. By the end of the operation, the patient was stable, but still critically ill. Perfusion was restored, vital signs normalized, and the aorta was mechanically secure. The immediate threat had been neutralized, but the process of recovery, the long, arduous path back to health, was just beginning. After the critical intraoperative complication was successfully managed, the patient was transferred to the intensive care unit, ICU, for close postoperative monitoring. His hemodynamics stabilized. Blood pressure remained within normal limits with minimal vasopressor support, and oxygen saturation returned to 98% on supplemental oxygen. Continuous ECG and arterial line monitoring allowed immediate detection of any hemodynamic fluctuations. Immediate postoperative phase. During the first 24 hours, the ICU team focused on maintaining organ perfusion and preventing complications. Blood pressure was carefully controlled to avoid excessive stress on the stent grafts while ensuring sufficient flow to vital organs. Serial laboratory testing monitored renal function, liver enzymes, coagulation parameters, and lactate levels. Creatinine, initially slightly elevated, began to normalize, indicating restored renal perfusion. Lactate levels decreased steadily, confirming reversal of systemic hypoperfusion. Neurological status was assessed hourly. Spinal cord ischemia is a known risk in thoracic aortic interventions, especially when distal branch vessels are involved. The patient exhibited no motor or sensory deficits, indicating preserved spinal cord function. Early mobilization protocols were planned to minimize the risk of ICU-acquired weakness and thrombosis. Recovery in the weeks following surgery. After stabilization, the patient was gradually weaned from mechanical ventilation and transferred to a step-down unit. A regimen of beta blockers and antihypertensives was initiated to control blood pressure and reduce stress on the repaired aorta. Nutrition, physical therapy, and psychological support became integral to recovery, as patients who undergo life-threatening emergencies often experience post-traumatic stress. A follow-up CT angiography 1 week post-procedure confirmed the integrity of the stent grafts, complete exclusion of the false lumens, and unimpeded flow to the branch vessels. No new dissections or complications were detected. The patient's functional recovery took several months. Initial limitations in endurance and strength were addressed through a carefully supervised rehabilitation program. Cardiopulmonary conditioning, gradual reintroduction of physical activity, and consistent blood pressure management were emphasized. He resumed normal daily activities within 3 months, but remained under lifelong vascular surveillance to monitor for late complications such as stent migration, aneurysmal degeneration, or secondary dissections. Long-term medical implications. This case illustrates several crucial medical lessons. Subtle symptoms can mask life-threatening conditions. Early signs, such as intermittent chest discomfort or back pressure, should not be dismissed, particularly in patients with risk factors or a family history of cardiovascular disease. Rapid diagnostic imaging is life-saving. Contrast-enhanced CT and intravascular ultrasound were essential in identifying the precise nature and extent of the aortic dissection. Team coordination and contingency planning are critical. The successful outcome depended on a multidisciplinary approach, clear communication, and pre-planned protocols for intraoperative complications. Minimally invasive interventions can reduce mortality and morbidity. Endovascular repair, TEVAR, allowed life-saving treatment without the extensive physiological stress of open surgery, demonstrating the advances of modern vascular medicine. Continuous post-operative monitoring and rehabilitation are vital. Recovery extends beyond the operating room. Attention to perfusion, organ function, blood pressure control, and patient education is necessary to ensure long-term survival and quality of life. Ultimately, the patient survived a condition that often proves fatal without immediate intervention. The precision, timing, and expertise of the medical team turned what could have been a catastrophic outcome into a story of survival. For medical professionals and viewers alike, this case underscores the importance of vigilance, rapid diagnostics, and coordinated intervention. In the delicate balance of modern medicine, seconds matter, decisions matter, and expertise can literally mean the difference between life and death.